This presentation is looking at the relationship between breathing pattern disorders, exhaustion, anxiety, and panic attacks. The autonomic nervous system of the body is there for maintaining homeostasis, and in doing so it regulates and coordinates many body activities including digestion, body temperature, blood pressure, and it's also associated with aspects of emotional behavior. There are two branches to the autonomic nervous system. The parasympathetic branch is taught to foster calm, physiological states to promote growth, restoration, and repair. The sympathetic nervous system activity is associated with fight or flight or mobilization behaviors and is typically activated during periods of stress or challenge. Where controlled and slow breathing comes in is that it activates the parasympathetic response, promotes homeostasis, and assists recovery and restoration of function in body systems disturbed by stress. Slow respiration in combination with prolonged exhalation may be particularly effective for reducing arousal. This maneuver for reducing arousal, for reducing stress, has been suggested by many yogi masters. In this paper, they look at three groups of people who practiced different breathing patterns. The first group, they inhaled quickly and they exhaled slowly. The second group, they inhaled slowly and exhaled quickly. And the third group, they had equal times in inhalation and exhalation. The researchers found that inhaling quickly and exhaling slowly was consistently effective for reducing physiological and psychological stress during confrontation periods. During rest, the ratio of the breath in to the breath out should be 1 to 1.5. The active part of the breath is the breath in, and the passive part of the breath is the breath out. But it's when your CP, when the control pause is high, above 25 seconds and ranging on 40, that breathing becomes light. And with light breathing, you've got a light, gentle, slow breath in, and you've got a relaxed, gentle, slow breath out. Individuals with a higher CP have a slow breath and they have a prolonged expiration. Conversely, individuals with a low control pause, low breath hold time, they exhibit faster breathing. Faster breathing is agitation of the mind and less likely to be calm. Very interesting study published by Stanford in March of 2017. Scientists in Stanford Medical School, they identified a small group of neurons that communicates the goings-on in the brain's respiratory control center to the structure responsible for generating arousal throughout the brain. So this new structure in the brain which they identified, it's spying on your breathing and relaying those findings to the rest of the brain. The structure, the locus coeruleus, it sends projections to practically every part of the brain, drives arousal, waking us from sleep, maintaining our alertness, and if excessive, triggering anxiety and distress. Now, this is very interesting, not just in terms of anxiety, but also in terms of sleep. One of the phenotypes of obstructive sleep apnea is low arousal threshold. A low arousal threshold means that the individual, that it's very easy for them to wake up out of lighter sleep, that they have sleep fragmentation. So what this is saying is that the newly identified structure, by spying on your breathing, that if you're breathing fast, you're more likely to be driving arousal and waking up from sleep. Low arousal threshold. When we get stressed, our breathing pattern changes. Our breathing becomes faster, we sigh more, we tend to breathe more through an open mouth, we have noticeable breathing, and we use the upper chest. And on the basis of that, the key aspect for bringing the body from a stress state into relaxation is to do the opposite. Stress breathing is fast, therefore to relax the body we should really slow down breathing. Stress breathing is irregular, therefore we need to emphasize regular breathing. Stress breathing is often through the mouth, therefore we need to breathe through the nose. Stressed breathing is noticeable breathing, therefore we need to enhance soft breathing. Stressed breathing is using the upper chest, therefore we need to learn diaphragmatic breathing. It's not a coincidence that the exact characteristics of our breathing during stress are the same characteristics that we typically see in a breathing pattern disorder. Stress changes breathing patterns, but breathing patterns if we have dysfunctional breathing, feeds back into stress. Fast, upper chest, mouth breathing causes stress. Stress causes fast, upper chest, mouth breathing, and there is a feedback loop there. It's almost that it's a vicious circle. So how should we breathe? Breathing should be light, quiet, effortless, soft, through the nose, diaphragmatic, rhythmic, and gently paused on the exhale. And this is how we would have breathed until the factors of modern living changed our breathing. So it's been known for many years that respiratory acidosis and alkalosis have profound effects on the functioning of the brain. Forrester, for example, reported in 1924 that hyperventilation can provoke seizures in epileptic patients and that the elevation of inspired CO2 concentration can suppress them. Now we know some of the functions of carbon dioxide. One, it's a catalyst for the release of oxygen from the red blood cells. So hemoglobin, which carries the vast majority of oxygen in our blood, 98% of it, carbon dioxide is a necessary gas because as there's an increase of carbon dioxide, blood pH drops and hemoglobin releases oxygen from the red blood cells to the cells. A second factor is the effect on our blood vessels. If we breathe hard, we're losing carbon dioxide, and by losing carbon dioxide, blood vessels constrict. McKeown in 1984, in a paper called Hyperventilation, a diagnosis begging for recognition, said that every 1 millimeter drop of CO2 reduces blood flow to the brain by 2%. We also know from other papers that 30 seconds of hard breathing can lower arterial CO2 from normal of 40 millimeter of mercury pressure down to 20. Well, if there's a 20 millimeter drop of arterial CO2, it translates into a 40% reduction of blood flow to the brain, and that's as a result of 30 seconds of hard breathing. The variations in the partial pressure of alveolar CO2, which is CO2 in the lungs, which in turn will equate generally with arterial CO2, could influence cerebral functioning in several ways. Molecular carbon dioxide itself, since it is soluble in the nerve membrane, could act as a narcotic gas. Carbon dioxide or tissue pH can influence neuronal functioning by altering cerebral blood flow. So we spoke about that. It's just one of the functions of carbon dioxide, thus altering the partial pressure of oxygen in the tissue. The more powerful effects of elevated CO2 may probably be explained by a direct effect on the neuronal membrane. The brain, by regulating breathing, controls its own excitability. Another aspect that's really worthwhile taking into consideration is that a biochemical feature of strong emotion is a rise in adrenaline and noradrenaline, and this has been shown to boost the body's sensitivity to carbon dioxide by about 30%, which in turn results in increased hyperventilation. The primary stimulus to breathe is carbon dioxide. The central chemoreceptors in the brain are monitoring mainly CO2 during regular breathing. But if you've got an increased sensitivity to carbon dioxide, it means that your breathing is going to be hard. And with hard and fast breathing, it's going to feed back into anxiety. So strong emotion, by changing and by increasing adrenaline and noradrenaline, is increasing the body's sensitivity to CO2. And with increased sensitivity to CO2, breathing is faster and it's feeding back into agitation. Is there a link between hyperventilation and exhaustion? Chronic stress is among the most common diagnoses in Sweden, most commonly in the form of exhaustion syndrome. We often see this in the corporate world. Individuals, they're under a lot of pressures. Employees are pitted against each other. Targets are set. There's a lot of competitive pressure, and employees, they're under a lot of stress in order to achieve these targets, and what's more, that these targets are changing. Severe stress symptoms occur if there's an imbalance between the investing and regaining of energy, and if it persists over a long period of time. In other words, as human beings, if we have a period of stress, we also need to have a period of relaxation for recuperation. But a good quality sleep is also conducive to this. If you were under stress during the day, it's very important that the body can recover by having deep quality sleep. But if you have an individual that due to prolonged stress, they can't switch off when they go to sleep, they have insomnia, they're twisting and turning all night, they're not having a deep sleep, so there's no time for the body to recover. Chronic stress symptoms usually occur within 3 areas: emotional exhaustion, physical tiredness, and cognitive difficulties. The majority of these patients with chronic exhaustion syndrome also have disturbed breathing, hyperventilation. 30 patients with exhaustion syndrome and 14 healthy subjects were evaluated with the Nijmegen symptom questionnaire. Patients with exhaustion syndrome reported significantly higher levels of hyperventilation as compared to healthy subjects. All patients' average score on the Nijmegen questionnaire was 26.57 with exhaustion syndrome, while that of the healthy subjects was 15.14. Nijmegen questionnaire is a series of questions, and if you score over 23 out of 64, it is suggestive that you have hyperventilation syndrome. Now, it's not surprising that individuals with exhaustion syndrome have hyperventilation syndrome. The stress response, which increases their breathing. The increased breathing takes its toll because there's a change in biochemistry of the blood, biomechanics of breathing, and feeding back into stress. And at some point, the body becomes exhausted. Even when the stress is removed, even if the individual gives up work and goes into rest and recovery, hyperventilation will continue. In other words, the behavior continues even when the stimulus is removed. And that's due to neuroplasticity. And this is why breathing rehabilitation, breathing re-education is also very important for people who are recovering from stress, from trauma, anxiety. So in this paper, they taught brief grounding training, and it contributed to a near significant reduction in hyperventilation and significant reductions in exhaustion scores and scores of depression and anxiety. The conclusion is that hyperventilation is common in exhaustion syndrome patients, and it can be reduced by systematic physical therapy such as grounding. In addressing hyperventilation, there is a need to slow down breathing volume, to reduce the respiratory rate, but also to make sure that the tidal volume isn't increasing as a compensatory mechanism. In other words, addressing hyperventilation is about reducing minute ventilation towards normal. We do that specifically, and what's more, we use the control pause measurement as a feedback of the sensitivity of the body to carbon dioxide. We want to reduce the sensitivity of the body to CO2, to reduce the ventilatory response to CO2, and we know that's happening when the control pause is increasing. A few weeks ago, I had a client presenting with bipolar depression. This lady has been suffering from bipolar for 20 years. And during the course of our conversation, I asked, how does she feel when she wakes up in the morning? She said she feels exhausted. I said, has your doctor ever said to you that you may need to do a sleep study? And she said no. Now the question here to ask is it that the bipolar is causing the sleep problems, or is it the inadequate sleep quality which is feeding into depression? Insomnia is a known risk factor for the incidence and severity of depression, the recurrence of depressive episodes, and even suicide. If sleep quality isn't right, how can the mind be right? There are several studies have shown that obstructive sleep apnea can also contribute to the development of depression. Now, in terms of breathing, when we are doing breathing re-education, we are looking at improving insomnia, to reduce insomnia, to achieve deeper sleep, that the individuals wake up feeling more refreshed. We are also using breathing re-education to help reduce neuronal excitability, to increase blood flow to the brain, but also to change the relationship between poor breathing patterns and stress and anxiety and depression. When insomnia and obstructive sleep apnea co-occurred, depression scores were higher than those with insomnia alone. So the individual, again, if they have insomnia and obstructive sleep apnea and are waking up exhausted, how do you know why are they waking up exhausted? Are they waking up exhausted due to the insomnia, or are they waking up exhausted due to the depression? And of course, if you're continuously exhausted and fatigued, you can't function in normal everyday life, and that in turn is going to increase anxiety and, of course, depression. As estimates of the prevalence of insomnia among OSA patients are as high as 67%, this finding suggests that many obstructive sleep apnea patients may be at risk of depression by virtue of the comorbid insomnia symptoms. The presence of daytime sequelae such as fatigue, irritability and cognitive symptoms are part of the diagnostic criteria for insomnia disorder. These daytime symptoms are often what prompt patients to seek treatment. However, daytime sleepiness, irritability, fatigue and cognitive dysfunction are also well characterized consequences of sleep apnea. So there's a commonality in terms of the symptoms, and can we help them? Yes, we can, by changing breathing patterns. This paper here is examining the relationship between respiratory regulation and childhood anxiety disorders of 104 children aged between 9 and 17 years of age. Childhood anxiety disorders, particularly separation anxiety disorders, are associated with CO2 hypersensitivity. Carbon dioxide hypersensitivity is associated with physiological changes similar to those found in panic disorders. Now, what does it mean, carbon dioxide hypersensitivity? It means that if there's an accumulation of carbon dioxide in the blood, and as carbon dioxide is the primary stimulus to breathe, you have an exaggerated response to the accumulation of CO2, your breathing is going to be harder. But also, if there's an accumulation of CO2 in the blood, when you've got a high sensitivity to it, you're more likely to feel suffocated. Now, the individual then who is feeling suffocated, that in turn will feed into symptoms of panic. They hyperventilate to get rid of too much CO2. Now there's reduced blood flow to the brain, there's reduced oxygen delivery to the brain. This in turn increases neuronal excitation. So a traditional remedy for somebody having a panic attack was to breathe in and out of a bag. The purpose of breathing in and out of a bag was not to bring in oxygen, but of course to trap carbon dioxide from the exhaled breath, to bring carbon dioxide into the lungs, to increase it in the blood, to increase blood flow to the brain, to increase oxygen delivery to the brain, to calm down the individual. However, it's not the stress that's the problem. The problem is everyday breathing patterns. When one is hypersensitive to carbon dioxide, it doesn't take much to push one into symptoms. These individuals are teetering on the brink of symptoms, and all it takes is a little bit of a stress, such as driving a car, being in a crowded place, etc., just to push one into symptoms. Carbon dioxide sensitivity is postulated to be a family risk marker of panic disorder. During CO2 inhalation, offspring with anxiety disorders relative to offspring without anxiety disorders experience significantly more panic symptoms and panic attacks, as well as elevated respiratory rates. So in the test, they would have individuals breathe in carbon dioxide just to see how is their body reacting to it. Now bear in mind, our body is producing carbon dioxide as a normal process of our metabolism. And the amount of carbon dioxide that we need in our blood, in our lungs, is about 5%. We can change the sensitivity of the body to carbon dioxide by deliberately slowing down the breath, and also by using very tailored breath hold exercises. So with a client coming into me, I will gauge if they have a hypersensitivity to carbon dioxide by virtue of their control pause. I can also gauge it when I have them do the exercises and I see how do they respond to the increase of CO2. Individuals with a strong sensitivity to CO2, we give them small breath hold exercises or small paces or gentle reduced breathing for very short periods of time. So for example, we want to restore nasal breathing and light breathing relaxation, but there is a specific protocol for individuals who are coming in with panic disorders, especially when they have a hypersensitivity to carbon dioxide. This is a really interesting study. It's looking at 41 patients with panic disorder and agoraphobia. They did 4 weeks of training aimed at altering either their respiration or they did cognitive training. The changes in respiration symptom appraisal, modality non-specific mediator were considered as possible mediators. So by slowing down the breath, they use capnometry assisted respiration training. So basically there's a feedback that the individual is following from a computer screen, and it's designed that you're following the movement on the screen and that you're slowing down your breathing in coherence with the movement on the screen. But what was interesting about it is that breathing retraining, but not cognitive training, led to corrections from initially hypocapnic to normocapnic ranges. In other words, the necessity with breathing re-education to normalize carbon dioxide. Patients learn to breathe in such a way as to reverse hyperventilation, a highly uncomfortable state whereby the bloodstream operates with abnormally low levels of carbon dioxide. Most panic disorder patients report that they are terrified of the physical symptoms such as shortness of breath or dizziness. But these symptoms are also typical symptoms that we see in individuals with hyperventilation related symptoms. But these symptoms are also symptoms that we see very much in patients with hyperventilation syndrome. In this study here, cognitive therapy didn't change respiratory physiology. That it was necessary to practice slow breathing to effectively reduce hyperventilation. So slow breathing was proved an effective and powerful treatment that reduces the panic by means of normalizing respiratory physiology. If you think of it, normally somebody with anxiety, somebody with panic disorders, they go to cognitive behavioral therapy, which is absolutely excellent. They do counseling. But it doesn't necessarily mean that the biochemistry and the physiology of their breathing is changing. We also need to address breathing pattern disorders, because otherwise, if they have a hypersensitivity to CO2, it's going to keep on feeding back into their symptoms. We also need to look at these individuals' sleep. We can't just rely on cognitive behavioral therapy. It produces results, but it's not the whole picture. Look at breathing, look at sleep, look at cognitive behavioral therapy. In this study, they found that slow breathing, it's the therapeutic change in carbon dioxide that changes the panic symptoms, not the vice versa. During the treatment, patients undergo simple breathing exercises twice a day. A portable capnometer device supplies feedback during the exercises on the patient's CO2 levels. The goal of these exercises is to reduce chronic and acute hyperventilation and associated physical symptoms, and it's the exact goal of when we're working with breathing re-education. The Buteyko breathing method was specifically designed to help reverse chronic hyperventilation. This is achieved by breathing slowly, but most importantly by breathing lightly. Contrary to lay belief, taking a deep breath actually worsens hyperventilation and symptoms. Now, historically, and also, we commonly hear it that when an individual is stressed, when they're feeling anxious, when they're feeling depressed, take a deep breath. They respond by taking this big breath, and of course the big breath isn't going to increase blood flow and oxygen delivery to the brain. The big breath will feel a little bit better because you're stretching everything and you're relaxing it, but it's not changing the biochemistry. In actual fact, a big breath taken every few minutes is enough to keep that person stuck in hyperventilation and stuck in symptoms. During cognitive behavioral therapy, if a patient reports shortness of breath, the therapist challenges the assumption by asking how often the person actually has suffocated during a panic attack, then hopes that this will reverse the patient's thinking. But shortness of breath is a typical symptom from breathing pattern disorders. The researcher continues that he finds the process is very challenging for some of his patients because it acknowledges the symptom but says it's not a problem. Slow breathing, however, tells us that a patient's CO2 is very low and is causing many of their symptoms. And it can also show how to change these symptoms through correct breathing. There has been an assumption that if people worry less about their symptoms, it will normalize their physiology, but this study shows that this is not the case. So even if the patient worries less about their symptoms, hyperventilation remains unchanged, and this is a risk factor for relapse down the road. Apart from hyperventilation being a symptom generator, it's an unhealthy biological state associated with negative health outcomes. Most investigators report an exaggerated response among individuals with panic disorder and at least some of the respiratory parameters. However, some studies have failed to observe this effect. There is an important link between respiration and arterial blood CO2 levels. Specifically, in terms of respiration, 3 parameters are responsible for controlling respiratory processes: arterial blood levels of oxygen, carbon dioxide and hydrogen ions. Amongst these, carbon dioxide provides the strongest stimulus to ventilation. For example, a slight increase of CO2, 2 to 5 millimeter of mercury pressure in the arterial blood can more than double ventilation. So in other words, carbon dioxide, that the body is very sensitive to an increase of CO2. But with some individuals, the body is overly sensitive to the increase of CO2. Findings show that individuals with panic disorders are prone to experience panic attacks when inhaling CO2 enriched air. This has given rise to the hypothesis that physiological systems underlying the experience of suffocation may be important in the etiology of panic disorders. What's causing the suffocation is the individual's sensitivity to carbon dioxide. And these individuals have abnormal breathing patterns. So I, as a breathing therapist, I look at the person coming into me with panic disorders. I see that they breathe fast, they sigh, they breathe often through an open mouth, they breathe using their upper chest, and I know by measuring their control pulse whether they have a hypersensitivity to buildup of CO2. Those individuals with a low control pulse, their breathing is very fast and they have an exaggerated response to the accumulation of carbon dioxide, and this can often be interpreted as suffocation, which of course is going to feed back in to the condition. In this paper, 40 individuals with panic disorders and 32 controls underwent both a breath-holding challenge and a CO2 rebreathing challenge. Individuals with panic disorders experienced elevated physiological reactivity to both challenges and a greater levels of suffocation sensations during the rebreathing challenge. And furthermore, panic disorder individuals who experienced a panic attack in response to the rebreathing challenge exhibited faster but shallower breathing during the challenge than did other panic disorder individuals. These findings are consistent with the theories linking panic disorders to hypersensitive brain systems underlying the experience of suffocation. The continuous rebreathing of 5% CO2 as well as inhalation of 35% CO2 has been found to initiate panic attacks significantly more often in individuals with panic disorders than in individuals with other anxiety disorders or unhealthy control. Furthermore, individuals with panic disorders experience CO2-induced panic attacks as being very similar to naturally occurring attacks. So again, it's the sensitivity, it's the feeling of suffocation brought about by the individual's sensitivity to the carbon dioxide and the same suffocation that they would experience during an attack. Consistent with most earlier studies, but not all, we found that individuals with panic disorders scored significantly higher than did healthy controls on subjective CO2 challenge responses. For example, panic attack rate and subjective suffocation, as well as respiratory-related CO2 challenge responses, breath-holding and ventilatory response. Briefly summarised, these models posit that a panic attack results from a catastrophic misinterpretation of bodily sensations which are seen as indicative of a serious physiological danger or loss of control. In my earlier years when I was working, and I still work with people with anxiety and panic disorders, however, experience is a great teacher. But in my earlier years, I would see people coming in with panic disorders. I would have them slow down their breathing to create air hunger, and I could witness that they were having panic sensations in front of me, that they had an immense fear as a result of air hunger. And as a result, over the years, I've had to tailor the exercises to suit these individuals to take into consideration the hypersensitivity that these people had to carbon dioxide. For hyperventilation, there is an accumulating evidence that at least some panic attacks are accompanied by drops in alveolar carbon dioxide. Between 61 and 83% of patients with agoraphobia with panic recognize the similarity of their symptoms of voluntary hyperventilation and their usual panic attacks. In other words, they have the individual breathe hard for 1 to 3 minutes, and that the symptoms produced during the hard breathing, during the hyperventilation provocation test, were similar to their normal panic attacks. Here we have to wonder about the connection between breathing hard and the initiation of the panic disorder and symptoms. Hyperventilation, it may take place chronically or in response to a provoking stimulus, such as being in a stressful environment or exercise. Really what it boils down to is the person's resilience. As human beings, we need to be able to cope with a certain amount of stress. We need to be able to cope with a certain amount of physical exercise. But if breathing patterns are dysfunctional, if we have developed chronic hyperventilation syndrome, our resilience is very much depleted. It doesn't take much to push us into symptoms. Normalizing breathing volume. The effect of breathing therapy was evaluated in patients with hyperventilation syndrome. Efforts to reduce ventilation through exclusive attention to the reduction in respiratory frequency may not be successful in reducing ventilation, but also can paradoxically increase ventilation. This point here is that if you are a counsellor or if you're a therapist and you're working with somebody presenting with hyperventilation syndrome, if you say to them, okay, your breathing is too fast, you are breathing 20 breaths per minute. Instead of breathing 20 breaths per minute, I need you to breathe 10 breaths per minute. Here you're looking to reduce the respiratory rate. But in that process, as this paper is pointing out, as the respiratory rate was reduced, the tidal volume increased. And not only that, it overly compensated that the actual minute ventilation was increasing. So that the reduction to the respiratory rate alone actually contributed to hyperventilation because minute ventilation increased as a result of it. If we are reducing respiratory rate, we also need to make sure that tidal volume doesn't increase overly to compensate. That we need to be looking at both the respiratory rate and the tidal volume to ensure that minute ventilation is reduced. So since ventilation is measured in terms of minute volume, the sum of the tidal volumes in each breath for 1 minute, a decline in the partial pressure of carbon dioxide accompanied by a decrease in respiratory rate can only be accomplished by a means of an increase in minute ventilation. So the point here is that yes, reducing respiratory rate alone, it can lead to an increase of minute ventilation, which corresponds to a decrease of the partial pressure of carbon dioxide. The influence of breathing retraining on complaints has been studied extensively in patients with hyperventilation syndrome and with anxiety disorders. The findings display a decrease of frequency and intensity of panic attacks and improvement of coping ability in stressful situations after breathing therapy. This was confirmed by the present study, that is, that the complaints and anxiety decreased significantly following breathing therapy. 10 of the 16 complaints of the Nijmegen questionnaire improved significantly. The state anxiety was reduced, however trait anxiety did not decrease, except in the patients who reported the largest subjective improvement. Breathing retraining, it markedly modified the breathing pattern, patients learning to breathe slower and older patients learning to breathe deeper. Several investigators mentioned a slowing down of breathing frequency and an increase of the fraction of expired carbon dioxide. Others, however, did not. The complaints which turned out to be linked to breathing were chest pain, a tense feeling, blurred vision, faster or deeper breathing, palpitations, and an anxious feeling. In the studies, carbon dioxide doesn't always show to improve. It therefore could be concluded that breathing retraining doesn't work because it corrects hyperventilation. In other words, the patients are feeling better, but what's actually happening here? Slowing down the breath, is it addressing hyperventilation or is it not? Because if carbon dioxide isn't showing to improve, it's not necessarily then due to hyperventilation, but it could be the mechanism of their breathing. We know that hard, fast, shallow breathing through the mouth will initiate and increase panic and anxiety. So therefore, the fundamental aspect of what we're looking to do is we're looking to make breathing through the nose, using the diaphragm in a slow manner, in a quiet manner, and regular. We know that breathing is happening more that way when the control pose is increasing. Our objective is that the individual develops light breathing both during wakefulness and during sleep. as key modifications in the quest for improving and reducing the symptoms of anxiety, stress, panic disorders, and depression.